Good afternoon, everyone, and welcome to today's webinar, Healthcare Reform, Where Are We Now? I'm Ronnie Musselwhite, Director of Content and Education for the NGCOA, and on behalf of the entire organization, thank you for your participation. Today's event will last approximately 55 minutes, followed by a Q&A session. This whole session is being recorded, and we will provide access to the webinar and all presentation slides soon after. We will also post this webinar on our NGCOA members-only networking site, Accelerate, where you can also find a full library of other webinars. Now, if you're like most Americans, you're not quite sure where things stand on the issue of the Affordable Care Act, but suffice it to say, it's been one of the hottest and most debated topics since the Trump administration took office in January. Today, we'll learn about the latest developments in healthcare reform and receive tips to ensure your business is in full compliance with the law. Now I'd like to introduce Kate Ball, who will present today's webinar. Kate serves as Area Assistant Vice President, Compliance Counsel for Arthur J. Gallagher & Company, a global brokerage for commercial insurance, employee benefits, and risk management solutions. In her role, Kate is responsible for assisting clients with group health compliance questions related to ERISA, HIPAA, COBRA, cafeteria plans, self-insured health plans, and healthcare reform. Her strong analytical skills and commitment to excellent customer service make her a trusted advisor to Gallagher's employees and clients in the South Central region. Now, if during today's session you have a question, please type it into the message box located at the bottom left-hand side of your screen. To submit your message, simply press Enter. Kate will field the questions and address them all at the end. Before we begin this webinar, again, I'd like to remind you that it's being recorded and we will make all those materials available to you. And with that, I'll turn things over to Kate. Kate?
Thanks, Ronnie. And thanks, everyone, for attending our webinar this afternoon. As Ronnie said, healthcare reform has been one of the hottest topics under the Trump administration. And even though there is a lot of buzz in a lot of different aspects of the Trump administration, healthcare reform is something that touches every American, and it affects a third of our economy, and it's a multi-trillion-dollar business. So it makes sense that Americans feel like they have a stake in pending legislation that could affect pretty much everyone in America. What we're going to do today is talk about what is at stake, which provisions of the Affordable Care Act are potentially being rolled back, what new provisions are we looking at with the AHCA, which is the new legislation that would replace parts of the Affordable Care Act. We'll talk about some other updates that Congress has been working on aside from ACA repeal, and we'll talk about what you need to do as a course owner in order to make sure that your health plan is in compliance. And then we'll save time for questions at the end, of course, as Ronnie noted. So topics of discussion today: what is PPACA, otherwise known as the Affordable Care Act, or Obamacare, and how does it work? This is not a new piece of legislation. It's been around for 7 years now. But it's important to understand how certain parts of Obamacare or PPACA work so that we understand what the effect of rolling it back will be when we're looking at some of the repeal legislation. Next, we'll talk about the AHCA, the American Health Care Act, also known as Trump Care or maybe Ryan Care, depending on who is taking credit for this new piece of legislation. We'll talk about how it works. It's pretty confusing, and that's because the House made a lot of last-minute changes before it passed the AHCA, so there's a lot of confusion out there, and we hope to clear some of that up today. Next, we'll talk about healthcare reform efforts outside of the American Health Care Act and talk about what you should do right now to stay in compliance. So what is PPACA or Obamacare, and how does it work? First, I want to note that PPACA was not the federal government's first attempt to regulate health care. Federal regulation of health care goes back all the way to the 1850s with the Bill for the Benefit of the Indigent and Sane, going to 1954 when Sections 105 and 106 were added to the Internal Revenue Code, and those are sections of the tax code that basically say that you as an employer get a tax break if you're going to offer health coverage to your employees. Normally, income is going to be taxed, but the government says that you get a break. It is designed to be a tax shelter if you offer health care to your employees, and that is how we developed the system that we have today, where the majority of Americans do receive their health care through their employer. It's due to that tax break. In the 60s, we saw Medicaid and Medicare, and we have some of our big federal statutes that still apply today: ERISA, HIPAA, COBRA, mental health parity. And then going fast forward to 2010 with the Patient Protection and Affordable Care Act, PPACA, also known as the ACA or Obamacare. Been in place for about 7 years now, and now we are contemplating a repeal of major parts of PPACA and a replacement with new legislation in the form of the American Health Care Act, or the AHCA. So some people have been calling this AHCA Healthcare Reform 2.0. Really, as you could see in the previous slide, there's a long line of the federal government regulating healthcare going back, over 100 years. So this is just a long line of efforts to drive behavior through taxation or through regulation, and we're going to talk about what exactly Congress is trying to drive our behaviors to do with the new piece of legislation. But first, let's talk about what PPACA does. You're probably familiar with a lot of these components. The individual mandate, it says that individuals need to get themselves coverage or face a penalty. Marketplace coverage and subsidies. So individuals can go to the marketplace, also known as healthcare.gov, and they can sign up for coverage and receive a subsidy to pay for that coverage. Employer shared responsibility for employers such as yourself is a big one. This is the pay or play mandate, and it says that employers need to offer health coverage to their full-time employees or else pay a penalty. Hand in hand with that employer shared responsibility mandate is employer reporting to the IRS in the form of 1095Cs and 1094Cs, which I'm sure many of you are familiar with. There are some new fees under PPACA, the PCORI transitional reinsurance fee, and the Cadillac tax, which is not yet effective and keeps getting pushed out further and further. And we'll talk about that with respect to the AHCA as well. And then there are some consumer protections that are actually quite popular amongst Americans. So we have the age 26 mandate, saying that adult children can stay on their parents' plan up to age 26. Pre-existing condition protection, so now insurance carriers may not deny coverage for pre-existing conditions, and in the individual market, they also can't, and the small group insurance market, they also can't rate coverage or charge people more because of their health status. There's the essential health benefits package, and that says that if you're in the individual or small group market, then your insurance plan has to cover 10 categories of essential health benefits, which are basically all things like that you would consider to be part of a major medical plan, like maternity care, hospitalization, pharmaceuticals, things like that. And then finally, coverage guarantees. So basically, the insurance carriers are restrained from declining coverage in certain situations. Out-of-pocket maximums are part of the ACA. That's why you have a cap on how much you might have to pay out of your own pocket on an annual basis. And there's also a prohibition on lifetime and annual limits, which did not exist before the ACA. And finally, as part of PPACA, Medicaid was expanded, and many states took up the offer to expand Medicaid. This is one of the big reasons why the uninsured rate in the United States dropped so much as a result of the Affordable Care Act. Medicaid expansion was a big part of that. People were eligible to sign up for Medicaid that had not been eligible before. So PPACA did all of those things, but not all of those components have rolled out in a completely smooth manner. There are definitely, if the PPACA were to stay in effect, and if the AHCA does not repeal it, there are definitely some things that could be improved. So let's talk about those. First, the individual mandate. The problem with that is that the penalty wasn't high enough to drive healthy people into the individual insurance market. So people would rather pay the penalty than pay for expensive coverage on the individual market. And what that means is we get adverse selection, which means that most of the people signing up for coverage on the individual market are not healthy. They actually need health insurance because they are sick, and premiums go up and up and up, and that's the death spiral that you probably keep hearing about in the news. The more premiums go up, the less healthy people want to sign up for coverage because they're paying for very expensive coverage that they might not need. So that's definitely problematic. The penalty, in order to drive behaviors and get healthy people to sign up for coverage, should have been much higher. Marketplace coverage and subsidies. The issue with that is that there are some areas with low carrier participation. And the reason for that is a lot of insurance carriers said that offering coverage to the marketplace was not profitable and that they were not reimbursed for losses in the marketplace like they were supposed to have been. So part of PPACA says that Congress will give funds to insurance carriers to make up for the fact that they're insuring mostly sick people, and some of those funds did not actually make it to the insurance carriers, and therefore some of them stopped participating in the marketplace. There are also other payments due to the insurance carriers from the federal government that are in question right now. And I think it was yesterday we had a recent development in a lawsuit over that, because it's basically up to the Trump administration whether or not they want to give that money to insurance carriers. If they don't give it to insurance carriers, then their participation in the market will probably decrease even further. So it's kind of in the Trump administration's hands right now whether or not insurance carriers continue to participate or start dropping out pretty significantly, and we'll see where that goes. I think in another 90 days we'll get an update on that lawsuit. Employer shared responsibility. As employers, you probably are very familiar with the fact that the rules implementing employer shared responsibility are complex and difficult to follow. And so is the reporting that goes hand in hand with employer shared responsibility, those 1095Cs and 1094Cs. Not only are those forms complicated, but there have been some problems with the IRS database with forms getting bounced back because there's a problem in the IRS database and it doesn't recognize the name and social security number of the individual in the form. For the age 26 mandate and the preexisting condition protections, essential health benefits, and coverage guarantees, basically all these things are great. They're popular. Americans love them, but they do increase the cost of coverage, especially the preexisting condition protections. That means that people who are already sick can sign up for insurance, and they start receiving a great amount of benefits even though they haven't really been paying into the system beforehand. So, of course, cost of coverage is going to go up, and that can dissuade healthy people from joining into the marketplace. The same with the out-of-pocket maximums and the rest of the consumer protections. The Medicaid expansion, the downside there is that 19 states declined to opt in. So we only have just over half of the states participating in that. So since Republicans gained control of the House in 2011, they've made continued legislative efforts to undo, update, or change PPACA. I think the latest count at the end of the Obama administration was that they made 80 attempts to repeal or change PPACA. Only one of those actually made it to Obama's desk. He, of course, vetoed it. But now that we have a different president who's not going to veto legislation to repeal the Affordable Care Act, we have our most serious effort to repeal and replace PPACA, and that is the American Health Care Act, or the AHCA. So what is the AHCA and how does it work? Well, it's helpful to go back to President Trump's campaign and his platform on health care. So here are the things that Trump said that he wanted to do with respect to health care. He wanted to repeal and replace PPACA. He wanted to permit insurance carriers to sell insurance across state lines, allow individuals to fully deduct their health insurance premium payments from their tax returns. He wanted greater use of HSAs, which is a popular Republican idea with regards to health care reform. HSAs are basically a savings account where individuals can stock away money that they own, and that is in their possession year after year, that they can use when medical expenses come up, or they can use even in retirement. President Trump campaigned on price transparency from all healthcare providers, block grants to states for Medicaid, which would decrease the federal government's costs with respect to Medicaid, but place a greater burden on the states, and improve access to prescription drugs, including lower exclusivity periods and imports from outside the U.S. As you probably know, drug costs are a major driver of increased healthcare spend in the United States, and hopefully Congress is going to work on solutions for lowering the cost of prescription drugs going forward, although that's not a major part of this bill. So that's what Trump wanted to do, but once he was sworn into office, reality started to hit, and surprisingly, it became clear that Republicans did not actually have a full consensus within themselves on the direction of the repeal and replace strategy. So there are some political roadblocks to a full repeal of the Affordable Care Act, and the first is in the House. We have two different major factions of Republicans, the Freedom Caucus and the Tuesday Group. The Freedom Caucus is definitely the more conservative faction, and they want a full repeal of the ACA. And we're going to talk about some reasons why a full repeal is not practical from a legislative perspective. So considering that reality, the Freedom Caucus would like something that is as close to a full repeal as possible. They want to get rid of as many government constraints on health care that are included in PPACA as possible. They want to go all the way to repeal or as close as we can get. Opposed to the Freedom Caucus, kind of on the other side of the Republican in the House, is the Tuesday Group. And these are more moderate Republicans who are concerned about the fact that certain parts of the Affordable Care Act are actually very popular amongst Americans and amongst their constituents. Those are the protections on preexisting conditions. They are the age 26 mandate, the out-of-pocket maximums. We'll talk about more of those later. But basically, the Tuesday Group says that they want to repeal some parts, but they want to keep the of PPACA, but maybe not those consumer protections because they know that Americans really value some of those. So without consensus here with these two groups, it was, as you probably know, when the House first tried to pass this piece of legislation, it was really hard to get enough votes to make it happen, basically, because you have two groups wanting kind of very different approaches to healthcare reform. And then if we move on to the Senate, who hasn't yet considered the bill, a variety of Republican senators have spoken out against the AHCA in its current form, but for different reasons. So some say it doesn't repeal enough of PPACA. These would be more conservative senators like Ted Cruz of Texas. Others are concerned that it eliminates or weakens popular consumer protections like we've talked about. And still others are concerned about the AHCA's defunding of Planned Parenthood, which is really a freeze of reimbursements from Medicaid to Planned Parenthood. And the problem with this is the fact that these senators don't approve of the AHCA for different reasons. So getting enough consensus and enough votes to actually pass this piece of legislation in the Senate might also be challenging, because if you move it in one direction to please one group, you're going to lose votes from the other group. So those are some of the political constraints on passage of PPACA. Let's talk about some legislative roadblocks to a full repeal. So this is the main reason why repealing and replacing the Affordable Care Act is so complicated. It's really because of Senate rules. So normally in the Senate, a simple majority or 51 votes is required to pass a bill. But the frequent threat of a filibuster means that practically speaking, a supermajority of 60 votes is actually required. So if we wanted to repeal or replace PPACA, we would need 60 votes. And that's because a supermajority voting in favor of PPACA isn't realistic, because Democrats are not going to get on board with a repeal of PPACA. And right now, Republicans have 52 votes in the Senate, so they don't have 60. They would need Democratic support to do a full repeal, which is not going to happen. However, there is a special legislative process called budget reconciliation that can be used to pass certain tax, spending, and debt limit legislation. So reconciliation bills are not subject to filibuster, so that they only need a simple majority to pass. So they need 51 votes to pass, and Republicans have 52 votes. So that's why they have decided to use this strategy in order to pass the AHCA. And that means that Republicans may be able to repeal some parts of PPACA using the reconciliation process, but it's important to remember that a full repeal is not possible because parts of PPACA fall outside of the scope of reconciliation. So reconciliation can only be used to pass tax, spending, and debt limit legislation. So if there is a part of PPACA that doesn't have to do with tax, spending, and debt limit, then it cannot be repealed through the reconciliation process. So just a little quick overview on how reconciliation works. The first step would be that Congress passes a budget resolution which contains a list of spending targets for the coming years and a set of instructions for how committees can hit those targets. And in this case, that budget resolution has been passed, and it said that the committees needed to hit the targets by repealing PPACA. So the second step would be that Senate committees work on legislation that hits the targets, and that legislation is brought to the Senate floor, where Democrats may challenge provisions and get a ruling from the parliamentarian. Parliamentarian is the person in the Senate that decides whether the rules are being followed. So we talked about the rule that this reconciliation process that's being used to pass the AHCA can only be used on tax, spending, and debt limit legislation. The parliamentarian is the one that would say, hey, this provision in the AHCA is subject to reconciliation and this provision is not. So they will be the final arbiter regarding whether the rules are being followed, and really will determine the parliamentarian will determine the scope of what can actually be repealed. So a little timeline on the AHCA started on March 6th when the House Ways and Means and Energy Committees released the first version. It's been modified a few times, and the Congressional Budget Office has scored it a few times, which means the CBO basically tells us what the financial impact will be of the legislation and how many people may or may not lose coverage. They have economists that have models, and that's how they calculate these things. It seemed that the AHCA was dead after March 24th when it became clear that House Republicans did not have enough votes to pass it. But it kind of sprang back to life in April when the MacArthur amendments were introduced, which basically gave the Freedom Caucus some of the things that they were asking for. Another amendment was introduced, the Upton Amendment, which created some additional funding to please the Tuesday group. And it did pass the House on May 4th, 217 to 213, so just barely. There's another important date on this timeline, and that is tomorrow, May 24th. There's an updated CBO score due. So the Congressional Budget Office has not scored the current version of the AHCA, which did pass the House. That score is due tomorrow. So it will be very interesting to see whether the piece of legislation hits the spending and deficit reduction targets that it was supposed to hit, and it will also be interesting to see how the CBO thinks consumers of healthcare will respond to the AHCA and whether or not they will stay insured, how many people will lose coverage, et cetera. So stay tuned for that tomorrow. We kind of talked about why the CBO score matters, so I'm going to go to the next slide. So what does the AHCA do? Well, we're gonna go over that, but I want to start with three big takeaways for employers. First, it effectively eliminates the employer mandate, and I say effectively because it doesn't eliminate it outright, because the reconciliation process won't allow it. Eliminating the employer mandate in and of itself is not directly affecting tax and spending. However, it effectively eliminates it because it zeroes out the penalties. So that is something that affects tax and spending. That's something they can do through reconciliation. So retroactive to the beginning of 2016, January 1st of 2016, there will be no more employer mandate penalties. So the employer mandate will still be on the books. There just will be no penalties. So, of course, a lot of employers are not going to comply. It lays the groundwork for simpler employer reporting. So again, because we're using reconciliation and we're not, and we're passing a very specialized type of tax and spending bill, we can't just get rid of 1095-Cs and say we don't want them to exist anymore. But what we can do is modify 1095-Cs and make them simpler, or perhaps even take a simpler form of reporting and take away the 1095-Cs and put it on the W-2. So that's something that isn't laid out in detail in the AHCA, but the AHCA says that the IRS should consider ways to simplify employer reporting. And then third, it keeps the Cadillac plan tax, which some of you might find surprising because in the presidential election, even Hillary Clinton campaigned on getting rid of the Cadillac tax. It's really unpopular on both sides of the aisle. But the AHCA actually keeps the Cadillac plan tax, probably because it needs those revenues. It needs revenues to pay for some of the programs that that the AHCA will roll out. But it delays it until 2026. And it will not tax high-cost employer-provided coverage in other ways, which is something that was suggested in previous versions of the bill. So some other changes that may affect your health plan: if you have a plan that incorporates a high-deductible health plan and a health savings account, there are changes. There are increases to the contribution limits, so people can contribute more to their HSA, and those people that are using HSAs can really get a lot more use out of them. And there are some other smaller changes. One of the big ones would be decreasing the penalty on money that you take out of your HSA and use on something that's not health related. The AHCA resurrects the rule that says that you can use your HSA, FSA, or HRA for over-the-counter medications. You used to be able to do that before PPACA or Obamacare. PPACA got rid of that rule and said that's not allowed anymore. The AHCA would say, no, that's a qualified medical expense. You can use those types of accounts to buy Tylenol at the pharmacy. It removes the dollar limit on salary reduction contributions to health FSAs. So employers would be able to set the limit on how much an employee can contribute to a health FSA, basically however they want. The sky's the limit there. It just has to be formalized in the plan document. Let's see. There's a big investment in the Patient and State Stability Fund. The reason why this is important is that $138 billion would be used to pay for coverage for people who are basically uninsurable because they are so sick. There are some changes to Medicaid, most importantly, rolling back PPACA's expansion of Medicaid. But there's a delay on that, and there's a one-year freeze on Planned Parenthood reimbursements, which isn't directly something that directly affects employers, but it does affect whether or not this piece of legislation will pass, because there are a couple of senators, Republican senators even, that have a problem with this provision, and so that might be a sticking point. And it repeals, the AHCA repeals some taxes as well. And there are three more big things that the AHCA does, and each one I wanted to dedicate a slide to it because they're pretty important and they're talked about a lot in the press, so I want to clear up any confusion on those points. First, it loosens age rating ratios from 3-to-1 to 5-to-1 for individual and small group plans. What does that mean? Right now, under PPACA, older populations can only be charged 3 times as much as younger populations. So there's a limit on how much you can charge older people who are covered under insurance. So they can only be charged 3 times as much as people in the lower age band. Under the AHCA, they'll be able to charge, insurance carriers will be able to charge 5 times as much. So that's a big change, and that could potentially make coverage a lot more expensive for people who are not yet old enough for Medicare, yet they're still in the individual insurance market, and they could be charged 5 times as much as a young person. PPACA had, obviously, tighter restrictions on that. The second really big change that you might have heard about is that the tax credits and subsidies are going to change quite a bit. Under PPACA, they are based on your income, and under the AHCA, they are going to be available to people who don't have access to employer or governmental health care coverage. The credits will range between $2,000 and $4,000 a person, capped at $14,000 a family. It will be phased out for individuals with incomes of $75,000 or $150,000 for joint filers. At first, this is kind of all there was under the AHCA, and interest groups like the AARP came out and said, hey, wait a minute, now older populations can be charged 5 times as much as younger populations, and we're getting, the tax credits are not going to be enough to make up for that. So there's potential under the AHCA for higher tax credits for individuals aged 50 to 64 to make up for the fact that they're going to have more expensive coverage because of loosening those restrictions on age rating. And then finally, this is the big one. This is the one that has been in the press and talked about a lot, continuous coverage. So If an individual goes longer than 63 days without continuous health insurance coverage in the prior 12 months, then insurers in the individual market can increase premiums 30% for 12 months. So basically, under PPACA right now, we have a penalty under the individual mandate if someone doesn't have health care coverage. And instead of paying a penalty to the government, individuals will now just pay a lot more to their insurance carrier when they do sign up for coverage. They'll pay 30% more for a year. And then after a year, the premiums will go back down. Now, you've probably noticed that I haven't talked about pre-existing conditions yet with respect to the AHCA, and that's because the piece of the legislation that affects pre-existing conditions was added pretty late in the MacArthur amendments right before the bill was passed. And pre-existing condition exclusions are probably not going to take effect in every state. So in addition to the 30% surcharge, like we just talked about, the current version of the AHCA says that states can decide to loosen restrictions even further. So not every state will take the federal government up on this, but if a certain state decides that it wants to take advantage of these waivers, then the state can do three things. First, it can say that insurers in that state are not required to cover essential health benefits. So those are 10 categories of services that you would consider as pretty integral to a major medical plan, like hospitalization, drugs, inpatient care, outpatient care, things like that. So a state can say that you don't need to cover that stuff anymore. And you can still sell that health insurance in the state. Right now, that is not the case. Insurance carriers do have to cover essential health benefits. Age rating, we talked about how older populations can be charged 5 times more than younger populations. If a state takes advantage of this waiver, they can increase that 5 to whatever they want. It could be 10 to 1. So they could make insurance even more expensive for older populations. And then finally, another thing that states can do if they decide to take advantage of the waivers is they can say, instead of imposing that 30% surcharge for people who did not have continuous coverage, we will allow insurers to underwrite based on health status for 1 year. So underwriting based on health status means that you will take someone's pre-existing condition into account when you set their premiums. So if a state decides to take advantage of this waiver, then insurance companies in that state can say, okay, John Doe, you have not had continuous coverage. You've gone 90 days without insurance coverage. Instead of charging a 30% surcharge for the next 12 months, we are going to set your premium at what we think it would actually cost to insure you. And we can see here in your health status questionnaire that you have prostate cancer. So we've determined that for the next 12 months, it's going to cost $140,000 to insure you. That is setting premiums based on a pre-existing condition, and that's something that is normally not allowed, but under the AHCA, there is a waiver system that allows states to implement that rule. So it's not necessarily going to happen nationwide, but if a state decides to take the federal government up on this offer, then insurance companies can charge more for people with pre-existing condition exclusions. However, I just want to emphasize that in order for that to happen, the individual would need to not have continuous coverage. So they would need to have a gap in coverage. So as long as somebody stays insured, the pre-existing condition issue should not really affect them because their premiums are not going to be set based on their pre-existing conditions. So I hope that clarifies that. If there are any questions at the end, I'd be happy to answer them. But the AHCA does not do a lot of things. It does not repeal a lot of key parts of PPACA, the adult dependent coverage requirement, the prohibition on annual and lifetime limits, preventive care requirements, waiting period limits, non-discrimination provisions, out-of-pocket maximums. It doesn't allow insurance or group health plans to deny coverage for pre-existing conditions. We talked about that state waiver that would allow them to charge an increased premium, but they cannot deny coverage. And just to be clear, that health status rating or charging more for pre-existing conditions is only in the individual market. So it's not in the small group market, it's not in the large group market. Not going to apply to employer plans. It just is going to apply in the individual market. The majority of Americans are not insured through the individual market. It's actually a pretty small percentage. But if you know anyone who currently has their insurance through healthcare.gov or is planning on getting insured there, those are the people that would be most affected by the pre-existing condition surcharge, essentially. So let's talk about those legislative roadblocks one more time, because that what we just talked about has kind of thrown a wrench into the passage of the AHCA, and that's because some of those provisions that we just talked about that are part of the AHCA may not fall within the scope of reconciliation because they're not directly affected by tax and spending. So the continuous coverage surcharge that says you'll pay 30% more if you don't have insurance coverage uninterrupted, that may not pass muster under reconciliation. And the state waivers as well, the elimination of essential health benefits, the age rating above 5 to 1, and the health status rating for pre-existing conditions, those things don't really directly affect the federal budget. So it'll be really interesting to see how the Senate parliamentarian, the person who's in charge of making sure that the rules are followed, it'll be interesting to see how this plays out in the Senate, because these are the provisions that really helped the bill pass the House, because the most conservative members really wanted to deregulate in this way. However, the deregulation is not directly affected by tax and spending, so it's really unclear whether these provisions, which have the biggest impact, of all the provisions in the law, these are the ones that you've heard about the most because they are, they're going to have the biggest effect. It's not clear that they can actually pass the Senate because the Senate is going to use the reconciliation process. Okay, let's quickly talk about some healthcare reform efforts outside of the Affordable Care Act. Before he left office on December 13th, President Obama signed the 21st Century Cures Act into law. And the biggest thing that course owners need to know about this is that if you are a small employer, so you have fewer than 50 full-time employees, then you can, instead of offering health insurance benefits to your employees, you can provide a health reimbursement account, an HRA, that reimburses employees for premium payments for health coverage. So you can give employees a pot of money and they can use that money to go buy coverage on the individual market or at the exchange. That was not allowed before. So this law changed that. Under PPACA, you could not use HRA funds to buy health insurance coverage and pay for the premiums. This has changed, but just for small employers. So you have to, you cannot be an applicable large employer subject to the employer mandate. If you're subject to the employer mandate, you may not take advantage of the qualified small employer HRA. But if you are a small employer, you may take advantage of it. Let's see, there's some rules here that President Trump, shortly after he was sworn in, he issued an executive order to minimize the unwarranted economic and regulatory burdens of PPACA. The IRS and CMS have done a few small things in reaction to this executive order, but executive order is not really how we govern in the United States, and there's not a lot you can do via executive order. So really the most interesting stuff that's happening in healthcare reform will not be in response to his executive order. It will be through legislation like the AHCA. All right. Since we have about 5 minutes left, I want to make sure we get to what should you be doing right now. So we've just done a crash course in healthcare reform 10.0, the AHCA, but it's not the law right now. The ACA is still the law of the land, and so we still need to comply with it. So my advice to you is to continue compliance efforts with PPACA. The ACA, that's going to be offers of coverage. If you are a large employer, you need to make sure you're offering coverage to your full-time employees. Make sure you're counting hours, and don't forget about your temp, part-time, and seasonal employees. Seasonal employees are always a big issue for course owners. Make sure you're counting hours for your seasonal employees, because there are some situations where you may actually have to offer coverage to a seasonal employee. And even if you don't, you need to be able to prove to the IRS that you have been counting hours and watching their hours to make sure that you're not subject to a requirement to offer them coverage. Make sure you're offering affordable coverage if you're subject to employer shared responsibility. Keep gathering data for your 1095Cs and your 1094Cs. As we discussed, the reporting requirement could become much simpler if the AHCA passes, but as we discussed today, that's a big if. It's still not clear that the AHCA is going to pass, or if it does pass, it's not clear that it will look exactly like it looks right now in its current form, the House version. Keep making your PCORI and transitional reinsurance fee payments if you are self-insured. And remember that your group health plan is regulated by many other mandates that are not the target of repeal efforts. So that includes ERISA, HIPAA, COBRA, Section 125, FMLA, and many, many more. The AHCA will not have an effect on those mandates. So under ERISA, make sure that you have a plan document and a summary plan description in place, and that you're distributing that summary plan description to your employees as required under ERISA. For HIPAA, if you have a group health plan, you should have a privacy officer, and you should have HIPAA privacy policies and procedures that outline how you will handle protected health information that you as a group health plan receive about your employees. COBRA, make sure that you're getting those COBRA forms and notices to employees in a timely manner. COBRA is an area of very big liability, and there's a lot of risk if you don't follow COBRA deadlines very strictly. So make sure that you're in compliance there. Section 125, if you allow your employees to pay for their share of the cost of benefits on a pre-tax basis through salary reductions, which I'm sure many of you do, make sure that you have a cafeteria plan document in place. That is a requirement if you want to enjoy that pre-tax treatment for your employees. FMLA, make sure that you have written policies and procedures that outline what happens when an employee goes on FMLA protected leave and non-protected leave, and how the employee's benefits will be treated during each type of leave, and how they will pay their share of premiums if they go on FMLA leave or non-protected leave. So there's still a lot to do in the compliance space while we wait and see what happens with the Affordable Care Act. But staying in compliance with PPACA, ACA, Obamacare is still very, very critical right now. The IRS certainly does have the authority to enforce penalties under the ACA while the law is still in effect. So with that, I will go to any questions. Let's see. Let's make sure I know how to pull these up. Hey, Ronnie, I saw the questions pop up, but can you give me a little bit of guidance on how to do that again?
Yeah, you should see, I have attendee chat pulled up. At the very top left, you should see attendee chat. Okay.
Perfect. Okay, thanks for that. Okay, so let me see what kind of questions we have. We have about 10 more minutes for questions, and I'm happy to answer these. And if you're thinking of questions now, feel free to enter them at this time. First question is there any language which defines eligible employees regarding full-time versus part-time? Is it 30 hours per week going to be the standard within the new plan? Is this relevant in the new plan? So that's a good question. So under PPACA, or the Affordable Care Act, there certainly is language that defines full-time versus part-time. And full-time would be your eligible employees if you want to avoid penalties, and part-time don't have to be eligible. The language, I wish it was a very nice, sweet, and simple definition, but it's not. It's about 30 pages of regulations in about 9-point font, double-sided. And those are basically the counting hours rules. So we talked about those rules as one of the downsides of PPACA, very, very difficult to comply with because the definition of full-time and part-time is 30 pages long. It's complicated. It's hard for employers to implement. Is this going to be relevant under the AHCA? Not really, because the AHCA will eliminate penalties for the employer mandate. So you'll no longer be penalized if you don't offer full-time employees coverage. So you can offer coverage to the employees that you want to offer coverage to, and you won't be subject to a penalty under the Affordable Care Act anymore. What I will say, though, is that there will still be some reporting where you have to tell the government whether or not you offered coverage to certain people, because if someone wants to go get a subsidy on the exchange to go buy coverage in the individual market, the government is going to need to know whether they had employer-sponsored coverage. So you'll just have to tell the government yes, no. You won't be penalized for not offering coverage, but you'll still need to report it. But no, the distinction between full and part-time will become much, much less important. The last thing I want to note about that is that apart from PPACA, there are rules under Section 125 and 105H of the tax code that basically says you cannot use your health plan to discriminate in favor of highly compensated employees. So if the employer mandate penalties go away, one thing I would say is that don't revert back to some system where you're only offering management benefits and nobody else is eligible. Because if you do that, you will be subject to some tax penalties. And actually, you can do it if you offer coverage on a post-tax basis, but you will basically lose every tax benefit available that you would normally get for offering coverage to your employees if you offer coverage in a discriminatory manner. So that would be the last remaining constraint on who you offer coverage to, is those tax rules. And my email is here on this slide right now. If anyone has questions about that, I'd be happy to give you more information about those non-discrimination rules. I have another question. Realizing you don't have a crystal ball, what provisions of the AHCA would likely have to change or be taken out to ultimately pass? That's a great question. I think that it's going to be really interesting to see whether the main provisions can pass muster. The surcharge for not having coverage, the state waivers for essential health benefits, age rating, and health status rating, or the pre-existing conditions. None of that stuff really directly affects the federal budget. So unless the Senate is going to get 60 votes to pass this thing, which they are not, because Democrats are not going to help them repeal Obamacare, then we are are subject to the reconciliation process, and those provisions don't affect tax and spending. So it's going to be really interesting to see how the Senate handles that. Like I said, there is someone at the Senate, the parliamentarian, that is in charge of determining whether or not the legislation that's introduced fits within the rules of reconciliation. They should follow the recommendation of the parliamentarian and take out any provisions that don't fit within reconciliation, but there is the possibility of what they call the nuclear option, which would mean that they would say, I know, Senate parliamentarian, you have told us that we cannot pass certain parts of this legislation within the boundaries of reconciliation, but we're going to do it anyway. And if they do that, then it will be convenient for Republicans right now, but it will not be so great when Democrats are in power someday, and the Democrats can just ignore those rules. So, the Senate is all about traditions and the way things have always been done and customary procedure, and once you undo that and say we're going to ignore the ruling of the parliamentarian, then, it's convenient in the short term, but long term not so much. So I will say that the repeal of the employer mandate penalties is something that does fall squarely within reconciliation. So I think that one is pretty safe. I don't really see, from a political standpoint or a legislative standpoint, a lot of barriers to repealing the employer mandate or employer shared responsibility. So for those of you who do have 50 or more full-time or full-time equivalent employees, you are subject to the employer mandate. If something is passed, ultimately, I do believe that it will include a repeal of those penalties. So in effect, the employer mandate won't really exist anymore. And the last question, when referring to full-time employees, are you talking about those working 40 hours or more per week? I'm actually talking about people who work 30 hours or more per week or 130 hours in a month, because that, in a nutshell, is the ACA's definition of a full-time employee. It's really 130 hours in a month. If someone works 130 hours in a month, you will have to offer them coverage, or if you don't, you'll have to put on your 1095-C, which is broken down on a person worked 130 hours and I did not offer them coverage. So right now the rule is you offer coverage to someone who works 130 hours in a week, or you can use the measurement and stability periods and average out their hours over 12 months. But if the employer mandate goes away, assuming the AHCA is passed, then you can come up with your own definition for what full-time is. Again, you can go back to 40 hours if you want, because there won't really be government legislation telling you, where to put that number. And that's all of the questions that I have, and I think we're just right about at our time. So I just want to say thanks again for your attendance today, and thanks so much for your questions. Feel free to email me at my email address on the current slide if you have any follow-up questions, and have a great afternoon.
Thank you, Kate. I believe it's safe to say this is a complex and ever-changing issue, and one that will continue to impact businesses for some time to come. Before we sign off, we'll look one more time to see if there are any questions. While we do that, I'd just like to remind you that we'll be providing access to this webinar and all presentation slides soon. We will also post this webinar on our NGCOA members-only networking site, Accelerate. And while you're there, again, I encourage you to check out the archive of exclusive webinars and other educational materials. It doesn't look like there's any additional questions, so with that, I'd like to thank Kate again for your time today and going through that and explaining exactly what is and isn't involved in these regulations, and also what employers need to be doing to stay compliant. And I'd also like to thank each of you who took the time out of your schedules to participate in today's webinar. And with that, until the next webinar, take care and goodbye.